Deborah Siegel. I'm a hematologist and clinician scientist at the University of Ottawa, and I was also principal investigator of the STRATUS trial. So it's my pleasure to discuss the findings of STRATUS with you today. Anemia is a common complication during hospitalization, but critically ill patients who are admitted to the intensive care unit or ICU are among the most high risk for anemia. After 1 week in the ICU, almost all admitted patients have some degree of anemia. Anemia in critically ill patients is multifactorial in nature, as is shown on this slide. Anemia leads to red blood cell transfusion, which is administered to up to 40% of patients in the ICU, so high rate of transfusion. And importantly, half of these transfusions are given without any evidence of active bleeding. Both anemia and red blood cell transfusion are associated with adverse harms in this population, including higher mortality, longer ICU and hospital stay, and transfusion harms. Among these etiologies of anemia, blood loss from laboratory testing appears to be the one that is a modifiable contributor to anemia and red blood cell transfusion, and it's iatrogenic in nature, which makes it a good target for intervention. We and others have reasoned that if we can reduce the volume of blood taken, we could impact anemia and transfusion in this population. It turns out that blood sampling for laboratory testing can actually cause substantial blood loss in ICU patients. We reported average volumes of over 200 milliliters per ICU stay. That's like almost a cup. And that incremental volumes of 150 milliliters increase the likelihood of red blood cell transfusion by over twofold. Another well-known US observational study showed that ICU patients experienced blood loss of 41 milliliters per day, which is like donating a unit of blood every 8 days. And importantly, 90% of the blood collected is discarded as waste. Only 10% of the blood collected is actually used for testing procedures. Tubes that automatically collect less blood are actually clinically available. These are so-called small volume tubes, and they're also called short draw or soft draw tubes. These tubes have less vacuum inside, so they fill to a smaller predetermined volume. Importantly, they have the same cost and the same physical dimensions as standard volume tubes and can be used on the same equipment. They also have the same method of blood collection. Despite these characteristics, they are not used routinely in adults. An example is shown on the left. The standard volume 2.7 ml citrate tube has an opaque blue cap, while the small volume or soft draw tube of 1.8 mL has a translucent cap. I want to just distinguish these tubes, which are vacuum filled, from the smaller microtainer tubes, which people may be familiar with from pediatric or neonatal settings. These pink cap tubes filled by capillary action do not have vacuum and therefore were not deemed to be implementable on a large scale because they require manual aliquoting both at the bedside and in the lab, raising concerns about health and safety and also workflow limitations, which meant that the small volume short draw or soft draw tubes were a good candidate for implementation and evaluation in a clinical trial like STRATUS. In summary, the rationale for conducting a clinical trial is that blood sampling contributes substantially to anemia and red blood cell transfusion in critically ill patients. 90% of the blood collected for testing is discarded as waste, so here's an opportunity to reduce volumes without compromising patient care. Lower volume tubes are available and compatible and have the same cost, but are not routinely used in adult patients. Therefore, we reasoned that a randomized control trial with clinical outcomes was needed to change practice. Our hypothesis was that transition to small volume blood collection tubes will reduce red blood cell transfusion in ICU patients. This slide summarizes the study design and population. STRATUS was a stepped wedge cluster randomized trial, and like other cluster randomized trials, the unit of randomization is the unit of care, and in this case, it's the ICU. Eligible ICUs were adult medical surgical units with 14 or more beds. They had the capacity for invasive mechanical ventilation, used standard volume tubes at baseline, and were able to transfer data electronically from hospital administrative and lab databases because this was the exclusive method of data collection for STRATUS. As you can see from the diagram, each ICU switched from standard to small volume tubes, but the timing of the switch was randomized according to a blinded schedule of randomization. At the beginning of the trial, all sites used standard volume tubes, which are shown in white, and at each step or 6-week time period, 2 sites switched to the small volume tubes, which are shown in light blue. At the end of the study, all the sites had switched over to small volume tubes. You'll see a pause in transitions at 7 sites, which is shown in red, which occurred at the onset of the COVID-19 pandemic. During this time, all the sites continued to use the tubes they were allocated, and data collection continued. The transitions resumed in August of 2020. We collected data for up to 30 days after ICU admission or until hospital discharge or death. And importantly, the study was conducted under a Research Ethics Board approved waiver of individual participant consent. 2 weeks prior to the switch date, sites were notified and brief targeted training was provided to nursing and laboratory staff. And these were the presentations and videos that we developed and tested in our pilot study. On the allocated switch dates, the standard volume tubes were removed from ICUs and the storage areas and replaced with small volume tubes. You can see on this slide the types of tubes that were transitioned and also their volumes. Of note, we didn't include blood culture or blood gas tubes in this trial. Outcome was the number of red blood cell units transfused per patient during ICU admission. The key secondary outcomes included the following: the proportion of samples that were reported as insufficient for analysis, which was determined to be the most important concern or harm of the use of small volume tubes. The proportion of patients who received red blood cell transfusion, the change in hemoglobin from admission to discharge from ICU, adjusted for red blood cell transfusion, ICU and hospital length of stay, and mortality in ICU and hospital. This slide summarizes our main analyses. Our primary analysis was limited to patients who were admitted to ICU for 48 hours or longer, as these are the patients who are most likely to experience the effect of repeated blood loss and also are at higher risk of red blood cell transfusion. We made the a priori decision to exclude patients admitted during the COVID hiatus, as there were concerns about differences in the healthcare environment and patient population at the time that would contribute to bias of our results. I talk about this in a subsequent slide. We used a negative binomial mixed model or hierarchical model, which was adjusted for age and sex. We included study periods modeled as a fixed effect and ICUs modeled as a random effect. And we included the duration of ICU stay as an offset to account for variations in the number of red blood cell transfusions administered during ICU stays of varying duration. Our secondary analyses included all patients admitted to the ICU for 48 hours or longer, including those admitted during the COVID hiatus. The proportion of specimens which were reported as insufficient for testing as the most important potential harm of using small volume tubes, mortality in ICU and hospital, the change in hemoglobin during ICU admission adjusted for red blood cell transfusion, and temporal trends in the effect of the COVID-19 pandemic. We also did sensitivity analyses to adjust for imbalanced baseline characteristics and also assessed for heterogeneity across sites. In total, 58 ICUs were assessed for eligibility, and of these, only 3 used small volume tubes at baseline. 30 declined to participate for undisclosed reasons. So we included 25 ICUs in the trial from Quebec, Ontario, New Brunswick, and Manitoba. Over the course of the trial, 51,037 patients were registered, including 23,320 who were admitted to ICU for less than 48 hours. So we analyzed a total of 27,411 patients. 21,201 were included in the primary analysis, 6,021 were admitted during the COVID hiatus, which left 27,411 in the secondary analysis of the entire cohort. This slide shows selected baseline characteristics. The dark gray middle columns show the primary analysis population of 21,000 patients, and the lighter gray columns on the right show the secondary analysis or total cohort of 27,000 patients. There are a variety of most responsible diagnoses here, which were determined using ICD codes from hospital administrative databases. You can see that there were some differences in baseline characteristics indicated in pink and with superscript, indicating a standardized difference of greater than 0.1. This slide shows the primary outcome of red blood cell units per patient per ICU stay. And it's important to note that 30% of patients admitted for 48 hours or longer received red blood cell transfusion. What we're showing here is the least squares mean, which is the mean from the model which accounted for the step wedge design, meaning periods modeled as fixed effects and ICU modeled as random effects, and adjusted for covariates. If we focus on the primary analysis population, you can see that there was a reduction in red blood cell units, which was not statistically significant, but corresponded to an absolute mean difference of 7.24 units per 100 patients. If we now focus on the secondary analysis population of 27,411 patients, you can see that there was a reduction in the mean number of red blood cell units after transition to small volume tubes, with a mean difference of minus 0.10, which corresponds to an absolute mean difference of 9.84 red blood cell units per 100 patients. This slide shows the proportion of specimens collected that were reported as insufficient quantity for analysis. This is the main concern about the use of small volume tubes. Among several 100,000 specimens in both populations, the proportion of specimens that were insufficient for lab testing was very low, 0.03% or lower, and similar between groups in both populations. We also examined the change in hemoglobin from ICU admission to ICU discharge. In the top row of the table, you can see that the decrease in hemoglobin, which was adjusted for red blood cell transfusions received, was smaller after the transition to small volume tubes in the whole overall cohort population. But this was not statistically significant in the primary analysis population, which excluded patients admitted during the COVID delay. However, the unadjusted change in hemoglobin was smaller after transition to small volume tubes in both analysis populations, was the change in hemoglobin among patients who did not receive transfusion. So in conclusion, transition from standard to small volume tubes in intensive care unit patients may reduce red blood cell transfusion in patients admitted for 48 hours or longer. We did not see a significant reduction in red blood cell transfusion in the primary analysis population, which excluded over 6,000 patients admitted during the COVID hiatus of the trial. However, in secondary analyses, red blood cell transfusion was lower among the larger cohort of all patients admitted for 48 hours or longer. Interestingly, the magnitude and direction of the effect on red blood cell transfusion was similar in both the primary and secondary analysis. However, the p-value associated with the analysis of the larger secondary population was significant, whereas that of the smaller cohort was not. The fall in hemoglobin concentration in both populations was also lower after transition to small volume tubes. So taken together, these findings support a possible small reduction in red blood cell transfusion and ICU-related fall in hemoglobin with transitioning to small volume tubes. Importantly, we showed no adverse effect on laboratory testing here measured as specimen insufficiency, which was deemed to be the most important potential harm associated with the use of small volume tubes based on stakeholder engagement. The strengths of our study included the use of a step wedge design, which is ideal for evaluating this type of intervention, one which has a high likelihood of benefit and low risk of harm, particularly in a complex care area like the ICU, where there are legitimate concerns about contamination of treatment arms, which precluded the use of individual patient randomization. The tubes were implemented easily into routine practice with brief targeted education, which was deemed to be scalable. We used pragmatic data collection from electronic sources exclusively, and this was quite cost effective. We included both community and academic sites, which enhances the generalizability of the findings. And finally, we saw a potential small effect at the individual level, but potential for a larger impact at the hospital or health system level or with respect to the blood product supply. Some important limitations included the changes in study conduct and primary analysis due to the COVID pandemic. And of course, we made the difficult decision to exclude patients admitted during that COVID hiatus due to concerns about potential for bias. There was limited availability on baseline characteristics and co-interventions just based on the nature of our data collection using administrative health sources. Transfusion and waste practices were not protocolized, although ICUs in general follow evidence-based guidelines for transfusion thresholds. And we only evaluated one aspect of lab testing, but this was the one that was deemed to be most important based on stakeholder discussions. This slide summarizes the potential impact of our findings. Over the course of the trial, 35,687 red blood cell transfusions were administered to the 27,000 patients admitted to the ICU for 48 hours or longer, with a reduction of 10 red blood cell units per 100 patients after transitioning to small volume tubes. We would have saved 1,400 red blood cell units in this trial alone, which speaks to the potential for impact for hospitals, health systems, and the supply of blood products in Canada if we consider that the cost of a unit of blood is about $1,000 with additional costs associated with indirect costs to hospitals and health systems. Blood product shortage is an issue in Canada and worldwide, and preservation of the blood supply is a high importance, now more than ever, to make sure that blood products are available for patients who need them. So I'd like to acknowledge the entire study team, without whom this trial would not have been completed. The study team members, our steering committee, the various site leads, the folks on the ground conducting the trial with us, and then our funding partners, particularly PHRI, for its fantastic support. And with that, I'll thank you for your attention.